Hello, everybody. Today's lecture topic will be craniofacial growth and development. This lecture will be done in two parts. So, today I'm going to do the first part of the lecture. Now, the learning objectives for this lecture is the student should be able to define the terminologies used to describe in relation to growth, identify the factors influencing the growth and development of the craniofacial structures, and outline the methods of measuring growth and explain the different theories of growth. Now have a look at some terminology. Now, what is meant by growth? There are various descriptions of growth, as for example, increase in size, change in proportion, and progressive complexity, and many others. And uh, it's also described as a progress towards maturity, and its Moyes describe it as naturally occurring unidirectional changes in life from existence as a single cell to its elaboration as a multifunctional unit, ultimately terminating in death. Okay, now there is a difference between growth and development. Growth means is the change in size and quantity which is measurable, whereas development is growth plus differentiation. Okay, what are the types of growth? Now, growth can be described at two levels, either at the cellular level or the tissue level. Okay, now growth at the cellular level, it can be either hyperplasia or hypertrophy. Now, hyperplasia means there is an increase in the number of cells via mitosis. Now, hypertrophy is merely the increase in size of the cells without the process of mitosis. So, the number of cells remain the same. Now, it can also be a combination of both hyperplasia and hypertrophy. Now, at the tissue level, we have interstitial growth, which results in lengthening of the bone. We have appositional growth, which results in increasing uh, thickness or increase in diameter. We have accretionary growth, whereby the growth happens by the accumulation of interstitial tissue around the cells. And there is also meristematic growth, which normally happens in plants, whereby the growing tip lengthens the root structure. Now, growth is a process, continuous process from the start of conception until death, but it varies in rate and duration for different parts of the body. So, thus, we can visualize growth as occurring in phases. Okay, the prenatal growth involves rapid cell division and fast growth rates. Now, the postnatal growth occurs from birth up to the age of 20 years old, and this is marked by declining growth rate but increasing maturation. Now, after 20 years of age is the period of maturity, which is a period of stability, and growth is limited to maintaining balance between cellular gain and loss. And in old age, there is a decline in functional activity, and thus growth slows down. Now, let's have a look at the factors affecting growth. Now, genetic factors. Now, genes control the magnitude and timing of growth, but the final outcome is determined by both genetic and environmental influences. Now, a good example of genetic role in growth is if we have look at two identical twins, we find that they have similar maturity indicators, wrist, dental, or sexual maturity indicators. And males grow over a longer period due to the delaying action of the Y chromosome, thus a greater overall growth. This again is another evidence support for the fact that growth is under genetic control. Okay, now hormonal control. Now, the growth is affected by various hormones, and in fact, you could probably say that almost all endocrine hormones have some effect on the growth. Now, the major hormones play having a role in growth is the growth hormone, also known as somatotrophin. There are growth factors such as IGF-1 and 2. They have platelet-derived growth factors, epidermal growth factors, and vascular endothelial growth factors, and we also have TGF-B. Now, insulin also plays a role in growth via protein synthesis. Thyroid hormones, androgens, gonadal hormones, PTH, and calcitonin. And all the tissues respond to the effect of somatotrophin. The level of somatotrophin normally reduces after puberty, and insulin affects growth indirectly by effect on the protein synthesis in the body. Thyroid hormones influence growth by the effect on metabolism and bone and dental maturation. PTH, parathyroid hormone, and calcitonin affects calcium metabolism and thus has an effect on bone physiology. Now, the pubertal growth spurt is affected by the androgens, which are secreted by the adrenal glands, as well as the gonadal hormones. Nutrition. Good nutrition is essential for growth, and by nutrition we mean sufficient calories, proteins, minerals such as calcium, phosphorus, manganese, magnesium, and fluoride, vitamins, especially vitamin A, B2, C, and D. Even oxygen has a role as an effect on growth. This can be seen in children with congenital cardiac defects, whereby they have stunted growth. And this is reversed once the cardiac defect is repaired by surgery. So, proper nutrition is important for normal postnatal growth. The minerals are essential for bone and teeth development. Vitamin A controls osteoblasts and osteoclasts. Vitamin B2 has an effect on growth. Vitamin C affects bone and connective tissue growth. Vitamin D is required for normal bone growth. And if nutrition improves, there is usually catch-up growth occurring. Secular trend. Now, what is meant by secular trend? This is a progressive tendency of changes that happens in consecutive generations, mostly observed in bodily development maturation during growth period or in adult sizes, and also in functional and psychological areas. For example, children today are growing faster than in the past. Between 1880 to 1960, the average height of Western children increased about half inch every 10 years to a maximum of 4 inches. And children are also stopping growth earlier now, and the pubertal growth spurt occurs earlier, and as well as the menarche also happens earlier. Now, this is probably due to better nutrition and better health care. Now, disease illness, prolonged and debilitating illness can cause a negative effect on growth. Now, during illness, there is increased cortisone production, and cortisone is an hormone that is antagonistic in its action to the growth hormone, and this cortisone causes arresting of cell growth, as can be seen as on X-rays as arrested growth. It can also be seen in the teeth as arrested development of the teeth. Now, after resolution of the illness, catch-up growth occurs and the child moves back to the predetermined growth curve. Now, season and circadian rhythms. Now, fluctuation in hormone release varies according to the time of the day. This is known as a circadian rhythm. Now, it is noted that growth in height is faster in spring as compared to autumn, whereas weight increases more in autumn compared to spring. And it is also noted that growth in height and eruption of the teeth is greater at night as compared to daytime. Cultural factors. Now, a study was made of comparing native Japanese males and Japanese males who were born in America, and it has found that the Japanese males who were born in America were much taller than their native counterparts. Now, psychological stress and psychological abuse can also adversely affect growth. This is believed to happen by inhibiting hormone release. Now, a study was done by Widdowson in 1951. He compared the height and weight of children in two German orphanages. Now, the children in orphanage with an harsh mistress had less height and weight gain, although they had 20% more calories, meaning better nutrition. Now, what are the methods available of studying physical growth? There's two big groups. One is either can be a measurement or it can be a experimental. Now, measurement, we have the technique called craniometry. Now, craniometry is done on skeletal remains. So, measurements are done directly on dried human skulls. 3D measurements are also possible, but because the subject is already dead, only cross-sectional studies are possible. It cannot elicit the size, amount, and rate of growth. Now, anthropometry, on the other hand, is measurements done on living individuals. The measurement is done on the soft tissue points overlying known bony landmarks, and soft tissue is thickness is variable, which has to be taken into consideration. Now, since the subjects are alive, longitudinal studies are possible, and this also cannot elicit the amount and size and amount of growth. Now, the head and facial shape varies among different geographical groups. For example, modern Caucasian skulls are large with large face and nose and long skull, as compared to modern East Asians who tend to have short flat faces and are lightly built. Now, indices can be used to describe the proportions independent of absolute size. Okay, let's have a look at the indices of anthropometry. that are commonly used. First, we have the cephalic or the cranial index. Now, the formula for this index is the maximum cranial width over the maximum cranial length times 100. Okay, and depending on the results, the head can be classified into various shapes. It's either dolichocephalic, mesocephalic, or brachycephalic. Okay. The second index is known as the facial index. Now, the formula for the facial index is the nasion height divided by the bizygomatic width times by 100. Again, based on the measurement, it can be classified. The face can be classified into three or more groups. Okay, the third index is known as the Palatine index, and the formula is the palate width divided by the palate length times 100. The next measurement technique is known as cephalometric radiography. Now, this is a technique used to study growth. It is used cephalometric landmarks on plotted on serial radiographs, and measurement on serial radiographs are analyzed to study the growth pattern. Now, the next experimental methods we have are vital staining. Now, vital staining involves injection of dyes that stain mineralizing tissues. Now, these dyes are incorporated into the teeth and bones, which enables study of the growth changes. Now, the experimental animals have to be killed so that the tissues can be stained and studied histologically. And because the subjects are killed, sacrificed, the longitudinal study is not possible. Common stains used for these techniques are alizarin S, procyon, tetracycline, trypan blue, and fluorochrome. Now we also have radioisotopes, whereby injection of radioactive substance that is incorporated into the developing bone. Now, by tracking the emitted radioactivity allows us to study the bone growth. And the substances used are calcium 45 and technetium 33. Expose a photographic emulsion plate, and this photographic emulsion plate exposed for suitable time and developed, and it produces a film which can be interpreted. The film is called a autoradiograph. Now, the substances commonly used are sodium, chlorine, fluorine, strontium, calcium, and iodine. Next is implant radiology. Now, implant radiology was introduced by Bjork in 1955. He inserted inert metallic tantalum pieces into a growing bone, and these metallic pieces become osteointegrated, and they act as radiographic reference points. Now, serial radiographs are taken at regular intervals, and through these serial radiographs, we can analyze the site, rate, amount, and direction of growth. And this technique allows longitudinal study of growth. Now, what are the various types of growth studies? You can divide into three types. One is cross-sectional, longitudinal, or mixed or semi-longitudinal. Now, cross-sectional means a large number of subjects are examined at one particular time. So this enables a large sample to be obtained, but the study period is usually short, and we can only arrive at a mean rate of growth for the population. Now, longitudinal studies, on the other hand, uh, studies done on the same subjects, whereby these subjects are followed up at regular intervals for a long period of study. Okay, as this allows velocity pattern and variability of growth to be analyzed. Now, the semi-longitudinal study is a combination of cross-sectional and longitudinal, and it has advantages of both cross-sectional and longitudinal studies. Now, how is the data from growth studies presented? These are usually presented graphically, which is easy to interpret and understand. And there's two types of graph. One is a distance or cumulative graph, whereby the height is plotted against the age. Now, the other type is known as the velocity or the incremental curve, whereby the rate of increase of the height is plotted against the age. Now, let's look at some basic concepts of growth. Now, pattern of growth. The human growth pattern is known as allometric. Now, what is meant by allometric growth pattern? With growth, it is the size increases and the shape changes as well. Okay, the opposite is what is known as isometric growth, whereby the shape remains the same throughout growth. Now, different parts and organs grow at different rates and different times. Now, differential growth in humans is reflected in the cephalocaudal gradient of growth and the Scammon's curve. Now, the cephalocaudal gradient of growth means there is an axis of increased growth from the head to the feet, and advancement of growth happens from the head, then the trunk, and then the limb. Therefore, the body proportions, overall body proportions, change from fetus to adulthood. Now, at birth, the at 3 months gestation, the head is about 50% of the total length of the body, half of the body, total length of the body. Now, at birth, the head is about quarter of the total length of the body, and as an adult, the head is about 1/8 of the total length of the body. Now, at birth, the nasomaxillary complex and mandible are less developed than the cranium. Now, the maxilla, being closer to the cranium, grows faster and completes growth earlier than the mandible. At birth, the cranium is more than 50% of the total head volume. Now, Scammon's growth curves. Now, different body tissues and organs have different growth rates and timing. And in 1930, Richard Scammon came up with 4 basic growth rates, which is the lymphoid, neural, general, and reproductive curves. Now, the lymphoid curve involves the thymus, adenoids, lymph nodes, and intestinal lymph vessels. Now, the lymphoid curve reaches 200% of the adult size between the ages of 10 to 15 years of age. Now, this is required as a protection against infections. After this, it reduces to the adult size by involution. The next curve is known as the neural curve. Now, this involves growth, development of the brain, spinal cord, and optic apparatus. Now, it's related to body parts of the cranium, orbit, and the vertebrae. Now, the brain reaches 90% of adult size by 8 years of age. Now next is the genital curve. Now this involves the primary growth of the primary sex apparatus, namely ovary and testes, and also the secondary sex characteristics. Now there's a small rise after birth, and at puberty there is a rapid acceleration which is known as the pubertal growth spurts, which occurs around 10 years of age. Now, if we apply Scammon's growth to the facial region, now the maxilla tends to follow a neural growth pattern, and growth ceases earlier in life. So this means that the skeletal problems in the maxilla has to be treated earlier. For example, for the use of face mask for growth modification must be done around 6 years of age. Now the mandible on the other hand follows the more closely the somatic growth pattern, and growth at the mandible continues until 18 to 20 years of age. Now any growth modification will need to be retained until 18 to 20 years, otherwise we will get relapse of the skeletal correction due to the continuing growth of the mandible. Now, the next concept in growth and development is variability. Variability is a law of nature. No two individuals have the same increment of growth at a particular age. There is variability in height and weight, and this variability can be caused by hereditary, by sex or gender, nutrition, racial, factors of exercise, climate, socio-economic or psychological. Okay, if you look at growth charts, there are growth charts which are separate for boys and girls, and within the boys or girls there are groups percentiles of growth. This means there is a variation among the particular population. Now the biological clock for every individual is set differently. Some individuals mature early, and thus they are taller in childhood than average growers, but as adults they may not be particularly tall. Now, females attain puberty earlier compared to males. Now, the human growth does not occur at a uniform rate. An example of this is the height. There are periods of relative quiescence whereby the height is not increasing by great amounts, interspersed with periods of rapid accelerated growth. Now, this period of rapid growth is known as a growth spurt. Now, usually in girls, the growth spurt occurs approximately 2 years compared to males. So we have three growth spurts, one happening around 3 years of age, known as the infantile growth spurt. We have a childhood growth spurt around 5 years, 5, 6 years, and the juvenile peak around 7 years, 7 to 8 years of age. And you also have the adolescent or prepubertal growth spurt. Now, what is the clinical significance of growth spurts? Okay, the prepubertal growth spurt has a major clinical implications in orthodontics. Growth modification procedures are best undertaken during the adolescent growth spurt. For example, chin cup therapy for class 3 patients, a Frankel function regulator twin block activator for class 2 skeletal correction, expansion of dental arches. So these are best done during the growth spurt. On the other hand, orthodontic surgical correction of gross skeletal discrepancy need to be undertaken after cessation of growth. Now, what are the controlling factors of craniofacial growth? You can divide them into three big groups. You have the genetic factors. Now, these are the factors that are inherent within the skull skeletal tissues. You have the epigenetic factors. Now, the epigenetic factors are also genetically determined, but it is determined via associated structures like the brain and orbit. And you have the environmental factors which can be local or general. Local is such, for example, the force of muscle acting on the skeletal bone, or you can have general factors like nutritional status. Now, what are growth fields and growth centers? Now, bone consists of an outer periosteal and an inner endosteal layers. Now, the bone is covered by soft tissues, cartilage, or osteogenic membrane. Now, growth fields are present in soft tissue matrix in a mosaic pattern, and these growth fields can either be depository or resorptive. Now, growth field is not located in the bone. Now, a growth center is a growth field but which is very active. Now, growth centers are where the genetically controlled growth occurs. Now, examples of growth centers in the craniofacial region are the cranial and facial sutures, the cranial base synchondrosis, the mandibular condyle, the maxillary tuberosity, and the alveolar processes. Now, growth sites are areas of bone where growth is occurring and they respond to external influences, but growth sites do not control the overall growth of the bone. Now, all growth centers are also growth sites, but not all growth sites are growth centers. Now, examples of growth sites are the mandibular condyle and the maxillary tuberosity. Now, modes of bone formation. There are two modes of bone formation. Now, one is the endochondral ossification, which gives rise to cartilaginous bone, and the other mode is intramembranous ossification, which gives rise to membranous bone. Now, endochondral ossification in a nutshell means there is a precursor cartilage template. Now, this cartilage template is surrounded by vascular mesenchyme, which contains osteoprogenitor cells, and centers of ossification appears in the cartilage matrix, and eventually the osteoblast deposit osteoid which mineralizes. Now, example of an endochondral ossification is the bones of the cranial base. Now, intramembranous ossification differs from endochondral bone ossification because this involves direct bone formation without any cartilage template. Now, it forms within highly vascular sheets of primitive mesenchyme, and centers of ossification appears in this primitive mesenchyme. Now, osteoblasts form from the ectomesenchymal stem cells, which forms osteoids, and eventually the osteoblasts become encased to form osteocytes. Now, blood vessels will be retained within these spaces, giving rise to what is known as Havian system, and the osteoid gradually becomes mineralized. Now, most craniofacial bones are the membranous type, and please remember that the mandible is also a membranous bone, and the condylar cartilage is a secondary cartilage, and it's not due to endochondral ossification. Now, what are the mechanisms of bone formation? We have three processes: bone remodeling, cortical drift, displacement, or translation. Now, bone does not grow uniformly, and usually there is selective bone resorption and deposition. Now, this selective resorption and deposition results in regional changes in the shape of the bone, size of the bone, and the proportion of the bone. Now, this constant reshaping maintains the basic shape and integrity of the bone. Now, sometimes regional adjustments are made to accommodate changes in function. Now, cortical drift, this was described by an Einlaw. Now, drift is the growth movement of the cortical plate. Now, bone apposition and resorption on opposing periosteal and endosteal surfaces of bone causes the cortical plate to drift in the direction of growth. Now, the thickness of the cortical plate may be maintained or changed according to the rates of apposition and resorption. Translation or displacement. This is a change in the spatial position of bone. Now, primary displacement is caused by enlargement of the bone that is moving itself. Example, in the translation of maxilla, where the posterior lengthening is equal to the forward movement of the maxilla. Now, in secondary displacement, the movement is caused by the growth of the adjacent bone. Now, let's have a look at the various theories of craniofacial development. Now, there are about 9 theories of craniofacial development, and we will look at them one by one. Okay, first let's have a look at the genetic theory, which was proposed by Brody in 1941. This is one of the earliest theory, and it simply states that genes control the overall growth and pattern of facial configuration. Now, this premise has been disputed by other authors who claim that it does not have complete control of growth. Now, the next theory is the sutural theory, which was proposed by Suture. Now, Suture considered that sutures are growth centers. Now, please recall that growth centers means the intrinsic control of growth is located in the growth center. Now, the sutures are able to generate tissue separating forces, as can be seen in the diagram. Now, it pushes the various bones of the craniofacial complex apart. Now, this theory has been disproved because sutures are believed to be adaptive, that is, they respond to stimuli rather than having intrinsic growth potential. Now, sutures are growth sites, not growth centers, because growth is secondary to functional needs. Now, if a suture is transplanted to another site, it does not produce growth, and the suture responds only to tension because compression causes resorption. The next theory is known as the cartilaginous theory, and this was put forward by James Scott. Now, he believed that cartilages are growth centers while sutures have secondary adaptive role. Now, cartilage are believed to contain intrinsic growth factors. Now, the primary growth centers as far as cartilage is concerned is the nasoseptum, which has an effect on the nasomaxillary complex, the condylar cartilage, which has an effect on the mandible, and the condocranium, which has an effect on the cranial base, otic, and nasal structures. Now, the the spino-occipital synchondrosis is actively growing until the age of 6 years. Now, what are the evidence that are used to support the cartilaginous theory? Now, the primary cartilage that is found in the craniofacial region, for example, the septal cartilage and cartilage, they are found to be identical to the epiphyseal plate of the long bones. Now, the epiphyseal plate of the long bones are the growing centers of the bones. Now, in rats and rabbits, it has been found that removal of nasal septum leads to mid-phase growth retardation. And many bones, as we know, grow by endochondral ossification. Now, if we transplant the epiphyseal plate or synchondrosis to another site, it continues to cause growth in those host areas. Trajectorial theory was proposed by von Meyer. It is it now bone is a very hard mineralized structure, but at the same time bone is very plastic and can undergo remodeling. Now the bone consists of bony trabeculae, and the orientation of this bony trabeculae corresponds to pathway of maximal stress and tension. Where the stress is more, we find the trabeculae is thicker. Now the direction of the trabeculae indicate the direction of the functional stresses, and these are known as Benioff lines. Now, Wolff's law of bone transformation says that a change in the stress of function leads to a change in the internal architecture and external form of the bone. And this change is achieved by selective remodeling. Now, when there's increased function, bone density increases. And if the function is decreased, then there's a corresponding decrease in bone density. Now, the maxilla, there are various trajectories in the maxilla which provides maximum strength to the maxilla with minimal bone material. Now, there are two groups of trajectories in the maxilla. One is known as the vertical trajectories. There are three of them. One is the frontonasal buttress. The next one is the mala zygomatic buttress, and the third one is the pterygoid buttress. And we also have horizontal trajectories. The horizontal trajectories are the hard palate, the orbital ridges, the zygomatic arch, and the lesser wing of the sphenoid. Now, the trajectories of the mandible can be considered major and minor. The major trajectories originate below the teeth in the alveolar process, and they join into a common pillar which protects the ID nerve and canal. Okay. Now the trajectory on the lower border of the mandible tends to resist bending forces. Now the next group is the minor trajectories. Now these are accessory trajectories due to muscle attachment. They are found in the symphysis and the corneal angle, and from the coronoid process into the ramus and body of the mandible. Now the next theory is the V principle, which was uh, proposed by Enlaw in 1996. Now, many facial bones have a V configuration or V-shaped regions. Now, bone deposition occurs on the inner surfaces of the V, while resorption occurs on the outer surfaces. Now, the result of this is that the bone enlarges while moving away from the tip of the V. If we look at the palate, there is deposition on the palatal periosteal surface, whereas simultaneously there is resorption on the nasal floor surface. In the mandible, the condyle and the ramus expand laterally and posteriorly due to this growth. Now, the counterpart principle, also proposed by Enlaw in the 60s. Now, it basically means that growth of any craniofacial structure is related specifically to certain other structural or geometric counterpart known as a growth equivalent. Now, ideally, amount, direction, and timing of growth must be balanced between counterparts. Now, examples of counterparts are the nasomaxillary complex and the anterior cranial fossa, the pharyngeal space and the middle cranial fossa, the maxillary corpus and the mandibular corpus, the maxillary tuberosity and the lingual tuberosity. Now, if we look at this diagram, this will explain how the counterpart principle works. Now, let's say we have uh, increase uh, increased growth of the maxilla, which causes the maxilla to translate in a forward direction. Now, with the maxilla gone forward direction, this causes imbalance in the occlusion of the teeth, and therefore the mandible will compensate by also moving forward. This is achieved by growth, which increases the length of the mandible to match the forward positioning of the maxilla. Okay, and the same applies for the growth in the vertical direction. So if this growth between the counterparts, for example, in this case, between the maxilla and mandible is unbalanced, then we will get various skeletal deformities such as class 2 or class 3 skeletal pattern. Now, the functional matrix theory. This theory was put forward by Melvin Morse in the 1960s, and this is probably one of the most widely accepted theories. Now, when the Claw in 1946 asserted that the skull consists of units, the size, shape, and position of the units are determined by their function. Now, non-osseous or functional matrix is more dominant than the skeletal units. The functional matrix has the primary growth function. Now, the skeletal units are adaptive and they respond secondarily. They do not have intrinsic growth potential. Okay, now this functional matrix theory by Morse. Okay, we have the functional cranial component, and this is divided into a skeletal unit and a functional unit. Now, the skeletal unit consists of microskeletal units, for example, alveolar bone, gonial angle, condylar portion, angular portion, and basal unit of mandible. And this microskeletal units combine to form a macroskeletal unit, for example, a mandible or maxilla. Now, the functional matrix can be either a capsular matrix or a periosteal matrix. Now the capsular matrix are neurocranial capsule and orofacial capsule. And this capsular matrix normally acts directly on the macroskeletal units, leading to growth. The periosteal matrix, on the other hand, which consists of muscles, tendons, nerves, blood vessels, glands, act on the microskeletal unit. Okay, and this is a better diagram. Okay, now the head is a composite structure. It has various functions such as neural function, olfaction, digestive, speech, audition, and vision. Now, each function is executed by a functional cranial component, and this is made up of a skeletal unit, microskeletal, which further divide into microskeletal and macroskeletal units. And there's a functional matrix which is divided into capsular matrix and periosteal matrix. Now, function requires spaces. For example, neural function, which is carried out by the brain, requires a cranial cavity. Respiration deglutition requires nasopharyngeal and oral spaces. Now, example of a capsular matrix is the neurocranial capsule, which consists of dura mater and scalp, and the expanding brain pushes skeletal units apart, and the periosteal matrix induces bone growth of the skeletal units. Now, the soft tissues or the functional matrix regulate growth of the skeletal units via functional stimuli, and these stimuli are transmitted to the skeletal units by what is known as neurotropism. Now, neurotropism involves exoplasmic transport resulting in interaction between the neurons and the innervated tissues. There are three types of tropism. One is neuroepithelial, which controls epithelial growth regeneration, and this is done by way of neurotropic substances found in the synapses. Now, when this tropism is deficient, we will see facial hyperplasia and cleft palate, among others. The second type of tropism is neuromuscular tropism, whereby it acts on the muscle, which is the part of the periosteal matrix, and it regulates the size and shape of the microskeletal units. But it can also exert its effect on the capsular matrix, which control the macroskeletal units. The third tropism is neurovisceral tropism, which regulates the growth of viscera, for example, the salivary glands. Now, what's the clinical significance of this functional matrix theory? Now, a prolonged mobilization of mandible and child retards mandibular growth because of the interruption of normal function. Orthodontic appliances alter the functional matrix. For example, for fixed braces, conventional fixed braces, alteration of the teeth, which represent the periosteal matrix, cause a change in the alveolar bone architecture, which is the microskeletal unit. Now, dentofacial orthopedics, which is alters the capsular matrix, alters the position of the jaws, which are the macroskeletal unit. Now, the servo system theory, this was proposed by Petrovic and Stutzman in 1980. Now, it's based on the cybernetic concept. Cybernetics is the science of control and communication in animals or machine. Now, cybernetics involves a closed loop system whereby there is a feedback loop and a comparator. Now the comparator compares the feedback stimuli from the output, and based on the feedback stimuli will regulate the input stimuli. So the input varies according to the output and other factors such as epigenetic and environmental. An example of the servo system in action can be seen in the growth of the mandible. Now, let's start with maxillary growth. When the maxilla grows forwards and downwards, the teeth will undergo a transient occlusal deviation. Now, this transient occlusal deviation will stimulate the proprioceptors and the periodontium and the temporomandibular joint. Now, this further activates the central nervous system, and this causes effect on the muscle function, which which causes protrusion of the mandible, and this results in condylar growth so that the occlusal deviation can be corrected. And here we can also get the system can be influenced by other factors like hormonal factors. Now, when Limbaug's compromise or composite theory, this was proposed by Van Limbaugh in the 1970s. It's a multifactorial. Van Limbaugh felt that there were some things acceptable in genetic, structural, and functional matrix theories, and some things which is not correct. So he made a compromise between the three different theories. Now, in the composite theory, the control for growth lies can be divided into 5 different groups. One is the intrinsic genetic factors. These are the factors that are resident within the skeletal units. You have the local epigenetic factors called the capsular matrix. Now, these are genetic influence from adjacent structures, example, the brain, eyes. The third one is the general epigenetic factors. These are genetic influence but coming from distant structures, example, growth and sex hormones. You have the local environmental factors. This is the periosteal matrix, and this is the local non-genetic external influence, for example, muscle force and habits. And you have the general environmental factors, and these factors such as nutrition and oxygen supply. Okay, that concludes our first part of the lecture for craniofacial growth and development. This is the references for the lecture, and thank you, and we will continue to the craniofacial growth part 2 soon.